Okay. We're recording. Thanks very much, Anna.
Okay, brilliant. So the way we normally work this is if you have some questions, throw it in the chat. Michael's going to be manning the chat as we go through. And if there's any themes that are coming up, we'll address those at the end. But anything that's not clear as I'm going through it, you feel free to jump in, shout, and I can stop and go through that again. That's no problem. Interactive is just so much better than talking to blank screens here. So I really appreciate the interruptions, to be honest. So I will move to share my PowerPoint screen. So there's a bit of a mix of abilities, which is always the case. I do feel that everyone benefits a bit from going through the probe positions, and I've thrown in a few tips and tricks on how to optimize your images in these. So I hope it's not too boring for those who are already FICE accredited. These are some things that I started to learn sort of 3 months into Echo in the Echo lab. I suddenly realized, oh, that's what you do to rectify this kind of image. So it's something I do try and teach people. So we'll gloss over the probe and the probe positions, but I'll give you some tricks on what you can do for each particular view. So obviously we're using a phased array transducer. This is the one with the smallest footprint on your machine. It's a low frequency probe, so it can penetrate quite deep. And depending on the machine you're using, it'll have just a very small dot at the top, which spreads out into a sector shape, or sometimes it's a small little curvilinear line at the top that spreads out to a sector shape. Some of the more modern machines have a sort of dual abdominal and phased array probe now. So those are the sort of images, fields of view that you'll expect to see on your screen. And it's a slightly different probe position as to what you've been used to with your fast scanning. So with your fast scanning, you've had your probe either to the patient's right or to the patient's head, and that's mostly inverted for echo. So you might want to have my little video image up as well for this, because I've got a probe in my hand. So there's a pointer on the probe, and imagine you're a clock face and your head, or the top of the head, is 12 o'clock. Then your right shoulder is 10 o'clock, your left shoulder is 2 o'clock. And that's what I'm referring to when I say 10 to 3. So in terms of the echo positions, the pointer needs to be pointed at 10 o'clock, 2 o'clock, or 3 o'clock. 10 o'clock is the parasternal long axis view, 2 o'clock is the parasternal short axis view, and the apical and subcostal views have the pointer towards 3 o'clock. So, and where are we going on the chest wall? So for the parasternal long axis view and the short axis view, anywhere along that left side of the sternum, generally I start around about the 3rd, 4th intercostal space, so the sort of lower third of it, lower 2/3 of it. If you're a bit more interested in the aorta, say you're looking for a type A dissection or widening of the aortic root, you might do a high parasternal long axis view, so a rib space up, so your sort of 3rd rib space. And if you've got someone with large lungs or elderly patients with very lean body habitus, you may find the only images you're getting are quite low down. So that's going to distort your image. It usually tilts it up a little bit. So that's a low parasternal long axis views. But anywhere along there is still that view. And once you find the right acoustic window, the right ultrasound window that gives you a good view of the valves, a good view of that central part of the left ventricle, that's the point that you stay on for your short axis views as well. So you just stay on that one acoustic window for both your parasternal long and short axis views. Once we move to the apical view, so that's the darker blue patch there. In men, I always say starts quite posteriorly, so mid to posterior axillary line, and start low. So a good 3 finger breadths below the nipple line to start with, angling your beam up towards where you can imagine the heart being in the chest. So one of the main problems that people do is they angle the beam sort of directly back as if it's going into the spine. And what you need to do is bring the tail of your probe down, and it shines the beam a bit more anteriorly in the chest, and that's where you'll start to get your images. And for your subcostal, so that's the red patch, we've still got our pointer towards 3 o'clock, and it's just in the squidgy bit, just underneath the xiphisternum. So those are the areas that we're going. with all my patients, I try and lie them on the left lateral position. So that it includes the parasternal views as well as the apical views. You'll see in textbooks and in online teaching, they roll patients to the apical views, but you'll find you get much better views for your parasternals if you roll them over as well. So left lateral position, their left arm goes behind their head like they're having a sunbathe, right arm on the hip, and you reach over the top of them and stick the probe on the wall. You're not really interested in where you're putting the probe, you're looking at the screen, and the screen will tell you if you're in the right position or not. Okay, so this is our parasternal long axis view. So this is quite a nice image because you can see how the beam is cutting through the heart. So we've got our pointer towards 10 o'clock, or the patient's right shoulder here. I'd have him rolled over a little bit, and we can see the beam just slices through just a little bit of that right ventricle that's coming over the front of the heart, but mostly what it's cutting through is the left ventricle, and right at the back there's a descending aorta as well. So we're expecting an image that's mostly left ventricle with just a little bit of right ventricle right at the top where the beam hits first. So that's what we're going to get. So here we've got parasternal long axis view. I don't think, I don't think you can see my pointer on this, can you? If you can, I'm pointing at it now. So at the top, you'll have this little bubble of, little bubble of right ventricle outflow tract. And then the rest of it is all this muscular left ventricle with your papillary muscles and your mitral valve. So ideally for this view, we'll have mitral valve and aortic valve roughly in the middle of the picture and a bit of a stretch of left ventricle, but you don't generally see the apex in this view. It'll cut off the apex. And you won't see more than just a little bit of right ventricle. So if you're starting to see a lot of tricuspid valve or a lot of pulmonary valve, something's not going quite right there. You might just see a little flicker of tricuspid valve at the bottom, but generally it should just be a little triangle or a little bubble of right ventricle outflow tract. So this is ideally what we'll be looking for. So this is a nice parasternal long axis view. If it was me, when I first put the probe on the patient, I try and increase the depth a little bit. We'll look for effusions underneath the heart. So there might be some pleural effusions you want to make note of. You want to see where that descending aorta is, which you'll see somewhere below that left atrium. And then you can always reduce your depth down and have a closer look at the structures inside the heart. So what can we see here? So my pointer at the moment is swiveling around where the mitral valve is, and you'll see there's two leaflets there flicking up, and this anterior leaflet here is touching the septum with every contraction as well, and that's a hallmark sign of good ventricular function, certainly in this area of the ventricle. The muscles, the walls are quite muscular, so they're nice, big and smooth, and as they contract, you can see they don't just move, they thicken as well. Then as we go through, the blood's going through the left atrium, through that mitral valve. You can see some papillary muscles there as well, and then gets ejected out through this. And this is the left ventricle outflow tract. And here is another valve. This is the aortic valve. So this is all left side of the heart, left atrium, mitral valve, left ventricle, through the left ventricle outflow tract and through the aortic valve. And then beyond the aortic valve, you have the aortic root. So this is the beginnings of the ascending aorta. And this at the top is just that little bit of right ventricle outflow tract that you can see. And here is that bit of tricuspid valve that I pointed out earlier. So in most of these views, you'll find that the right ventricle is on top of the view. It's the first structure the ultrasound beam hits. So it's going to be at the top of your image. So what can we do to alter our parasternal long axis view? So this is something that a lot of people get wrong and don't know how to adjust. So when people put their probes on, they might find that this bit of valve comes in down the right side of your image. So at times this looks like quite a nice parasternal long axis view. I've got my mitral, my aortic valve, and then this structure here comes into play. And this is actually, so that's just coming down the right side there, and it obscures the aortic valve. That is the right ventricle inflow, just here coming into view. And what that does is open up the right ventricle in the tricuspid valve. So you're not getting, basically you're obscuring the aorta and the left ventricle outflow tract. So this is now covering and coming over the top of where the aorta is. So your beam's a little bit too anterior in the chest, really. So what's happened, if you look at my image on the right there, is I've actually put the tail of my probe, and imagine that cord coming out of the probe is the tail. The tail is a little bit too far up, and that means the beam has come a little bit too far forward in my chest, and it's opened up the more anterior structure, which is the right ventricle inflow. So it is actually a view that we seek out in the echo lab. It's one of the ones we use to get our right-sided pressures. But often people think they've got a parasternal long axis view, and actually there's too much right ventricle in that view. So what do you do to correct it? You just bring that tail down a little bit, and you'll find it opens out, and you've got that aortic valve back in the middle of the picture. And that's the biggest mistake I see people make when they're trying to get a parasternal long axis view, putting on this left-hand image, we can see and the beam again is just too anterior, but now it's looking up rather than down the heart. So this is a pulmonary valve view.
Have we just lost our presenter? I seem to have lost her on my... Did everyone else just have Anna drop off?
Yeah, she's dropped off for me too.
Okay, great. Hopefully she'll be reconnecting shortly. Just while she's reconnecting, I've just posted in the chat a couple of things you might be interested in. Firstly, the link to the Slack group that I mentioned. And then also I've just put a link to a great online simulator, which I discovered a few years ago. It's actually from Toronto in Canada. If you like, you could bring up the link now. It's the PIE at Toronto. It's just got some great simulated views of all the basic echo views. Oh, hey, Anna, welcome back.
Hi, I'm sorry, I'm having a bit of a mare.
No worries.
Right, okay, let's try again. Are you on my screen at the moment? No, I presume.
No, you have to reshare.
All right, hang on. I do miss face-to-face teaching. I used to like it.
Mm.
Okay. So this is where I think I lost you. So another thing that can go wrong with your parasternal long axis views, you can over or under rotate. So this is me just turning the probe a little bit more one way than the other. So we are trying to aim towards the right shoulder, but people's anatomy vary a little bit. So potentially you're a couple too many degrees clockwise or anti-clockwise. And what happens is what you can see on the left there, you can see that left ventricle shortens. It becomes short and fat rather than long and lean. So if you see a short fat ventricle, and if you can see the apex, you have over-rotated either one way or the other, and you just need to turn it one way and try and elongate it out. So you really shouldn't be seeing the apex in this view. So this view on the right, we're actually, on the left, sorry, we're actually starting to head towards more of a short axis view. So we just need to rotate a few degrees anti-clockwise back again, and you'll see that aortic valve opening and the left ventricle elongating. Okay, so now we're going to turn the probe all the way 90 degrees. So it's pointing towards the patient's left shoulder. Again, I'd have the patient on the left lateral position. and it's taking a slice in cross section somewhere through the heart. So the beam can end up somewhere near the top, the middle, or the bottom. At the top of the heart, we've got the aortic valve and all the big vessels that come out the top. And in the middle, we've got the mitral valve, and towards the bottom, we've got mid-ventricle, papillary muscles, and then as we go down, the apex of the heart. So depending on which angle you've got that tail, depends on whether you're getting a low view or a high view in short axis. So we've rotated the probe 90 degrees, and we're going to look at the screen until everything rounds off and it looks like it's in cross section, and you'll end up in one of these levels or somewhere between. So at the top, we've got aortic valve level, and we always talk about it as a Mercedes-Benz sign. So most people have 3 aortic valve cusps, and they come together a bit like a peace sign or Mercedes-Benz. The level below that would be the mitral valve. So this aortic valve will kind of spread and get bigger and turn into this larger circle with 2 leaflets in it. That's the mitral valve, and they should open towards you like a fish mouth or a chatty mouth. And then a level down below that is the papillary muscles, and below that you'll lose papillary muscles and just end up with a muscular ring that gets smaller and smaller. So this is the aortic valve level. We've got these 3 cusps in the middle. And this is actually somewhere between the aortic valve and the mitral valve. And this is often what happens. People turn the probe and they're between those 2 levels. So as you can see, the aortic valve, the Mercedes-Benz sign is there, but the bottom of it is moving. And every now and then it turns into the mitral valve that opens towards you. So if that happens when you turn your probe, just commit one way or the other. So commit by putting the tail of your probe down, looking higher up the heart, and you'll see the aortic valve, or putting the tail of your probe up, looking down the heart, and you'll get closer to the mitral valve. So this is the ideal aortic valve level. So nothing at the bottom is opening up. It's all one structure. About 2% of the population will have a bicuspid aortic valve. So a couple of these cusps will be fused, or sometimes it just looks like 2 separate cusps. If you do incidentally find one of those, which will probably happen if you're doing more and more, they just need regular follow-up. So they do need annual follow-up with an echo, because they're prone to aortic stenosis, and most of them go on to having a valve replacement at some point in their life. So it does need a letter to the GP saying this was incidentally found. They will need annual surveillance. This is the mitral valve level. So we've just gone tail up, beam down, looking down the axis of the heart. And now we've found a round structure, round left ventricle with 2 leaflets opening towards me. That's the mitral valve. And at this point, it's important to start to notice what's happening with the right ventricle. So in all these images, the right ventricle should be nice and crescent shape. It should be rounded. And the septum between the right and the left ventricle should be curved. So the left ventricle should stay a donut shape, shouldn't be bounced or squeezed by the right ventricle, and the right ventricle should stay a crescent shape, because that's the lower pressure chamber. So the left ventricle's boss and the right ventricle's just there for the ride. Going down a level again, we've come down to the papillary muscle. So this is just below the mitral valve. Often people go a bit too fast and skip over this. 2 papillary muscles in most people, one for the anterior and the posterior mitral valve leaflets. But below that, you've got a sort of mid-ventricle or apical view. So the donut just becomes smaller and smaller, and the right ventricle you'll see is still this crescent shape, sort of hugging it round the edge, but the septum is still curved. And that's quite crucial, because when that right ventricle starts to come under pressure, it starts to flatten that septum. We'll have a look at that a little bit later. Okay, so this is just going all the way from the top of the heart to the bottom of the heart. So you'll have your pointer towards the patient's left shoulder, or 2 o'clock, and you'll just be putting your tail up to look down the heart, or down to look up the heart, and go all the way from the top to the bottom without moving from that one spot. Okay, so now for the first time, we're taking the probe off the parasternal region and moving it to the apical region. And we can see we're quite low. We're actually a good few finger breadths down below the level of the apex of the heart, and we're much more lateral than where the apex of the heart is, so that the beam has space to come up through it. And you see the angle of the beam is quite shallow, so it's quite anterior in the patient's chest. And the pointer, it's not really clear on this view, should be towards 3 o'clock. So if the patient's rolled over onto their side, it's generally into the bed. And that does vary a little bit from person to person. You might turn it a little bit towards 2 o'clock, but generally it's between 2 and 3. And if you've got it just right, and if you've got it lateral enough, you should have an image that looks a bit like this. So 4 chambers opening up. Generally, people start to see a left and right ventricle flickering away, and then as they bring the tail of the probe down and bring the beam anterior in the chest, then these atria start to open up as well. And we've got 2 valves in this view, mitral valve, which is sitting just slightly lower than the tricuspid valve. And in an ideal world, we'll see the annulus of both of those valves as well. So the right ventricle or the tricuspid annulus and the mitral valve annulus. And that becomes useful when we're using some of the quantitative methods to look for right ventricle or left ventricle function. So what happens if you've got your beam the wrong way round, your probe the wrong way round? We need to know what a left ventricle normally looks like and need to be able to recognize when we've done that. So the left ventricle is smooth walled and muscular. The right ventricle is trabeculated, a bit rougher in the walls. And a lot of patients will have a moderator band. This is a false tendon that's towards the top of the right ventricle. So that's how you know it's RV rather than LV. And as I said before, the tricuspid valve sits a little bit higher than the mitral valve usually. So just a couple of things to look out for to help you recognize whether you've got your probe the wrong way around, because it still happens. Okay, so this is a nice elongated looking apical 4-chamber view. So this happens quite a lot where you lose a little bit of either the left ventricle or the right ventricle. So here we've lost a little bit of the tricuspid annulus. But what's great about this is it's a really long looking left ventricle, and that's how I know it's on axis. So we've taken the right slice through the heart. If you see the apex coming down like that, again, it means that you've got your slice slightly wrong. It's called a foreshortened view. So the beam, rather than coming up through the ventricle, is going slightly obliquely, cutting through either the anterior or the posterior wall a bit too soon, and you'll see the apex coming down. So if that happens, usually the correction involves going lateral on the patient's chest wall and a bit further down, so a rib space also down the body, so you're a little bit further away from the heart to elongate that view. If you want to open up the aortic valve in the middle and create a 5-chamber view, at this point you've got your beam like this going up through the anterior chest wall, and all you do is bring the tail down a little bit more. So tail down, beam more anterior in the chest wall, and it'll open up this 5th chamber, which is the aortic valve in the middle. Some people will find that they were always getting 5 chambers. Some people will find they're always getting 4 chambers. So just practice switching between the 2 of them. It becomes relevant when you start to do some more advanced echo and you start to use spectral Doppler and do some hemodynamic studies. That view allows you to estimate things like stroke volume and cardiac output, and your aortic valve area. So it's a useful view to know how to get consistently, but either the 5 and the 4-chamber view will give you the information you need for a basic focused echo in terms of how well the left ventricle is functioning and how well the right ventricle is functioning and whether it looks like it's under pressure or not. So subcostal view, so again, the probe has come off the patient's body. Up until this point, you've been holding your probe a bit like a pencil, so fingers sort of towards the bottom of it so you can have good control. But for this one, I would put your hand over the top of the probe so that you can put a little bit of pressure on it and push up into the xiphisternum. So if you're holding it like a pencil, your hand gets trapped underneath it and you can't flatten it against the patient's body. So if we've got that right and we've got the hand over the top, this beam will be nice and flat, nice and anterior in the patient's body, and we should open up a 4-chamber view from the subcostal view. So you'll see 2 ventricles and 2 atria. Something like that. So again, with this view, just like with the long axis and short axis views, the right ventricle is on top. So it's the one that's closest to the liver, it's the most anterior structure, and it's the bit that the beam will hit first. So depending on your angle of your probe, you might again open up the aortic valve in the middle. So people often mistake what they think might be a left atrium, but it's actually an aortic valve in the middle. So you might get a sort of 5-chamber subcostal view rather than a 4-chamber view. And to correct that, you just do a little bit of angulation. And in that subcostal area, we're also going to try and find the IVC. So we use the IVC to decide whether a patient is fluid tolerant. There have been various studies saying it's a pretty good surrogate for whether a patient is fluid tolerant and for goal-directed therapy. Lots of chat about that, and it gets quite complicated when people are ventilated. But generally, we measure it about 3 centimeters from where it enters the right atrium through this path of the liver, and you'll find that there's a attributing hepatic vein that joins just before the right atrium, and that's a good landmark, measuring it about 1 centimeter proximal to that, or sorry, actually distal to that, sorry, will give you a nice reproducible measurement. I don't like discrete values for IVCs. The upper limit of normal is supposed to be somewhere around 2.5, but everyone's IVC is different. So it's more for me about the collapsibility. It should be collapsing more than 50% of its diameter with every breath. And so if you've got an IVC that looks normal size, not absolutely gigantic, and is collapsing, then that patient is fluid tolerant. So if you've got someone who looks dry, looks septic, but you're worried because they've got heart failure, but it's collapsing nicely, it's got some room for fluid, you can always give them a bolus, have another look with your ultrasound scanner and see where you are, and then keep going until it's no longer collapsing 50%. So this is just a subcostal view. And this is my little dance that I do to find the IVC. So everyone's got their own way. So on the right, you might have to move the little people. I've got my probe position firstly towards 3 o'clock. So when we first put it on, the pointer is towards 3. Then I turn the probe towards the liver, and then I flip it on its axis so that it's in a longitudinal axis with the pointer upwards, and then I fan the beam through until I find the IVC. So it goes on the body, find a subcostal view, turn the probe towards where the liver is, and you'll find this sort of knuckle of liver coming into view, flip the probe on its side, and then fan through until you find the IVC. So turn, flip, fan. So on the left, this is the image you'll get as you turn, so a bit more liver comes into view. Try and get it so that the right atrium is still in the screen, but all the way over to that right side, so you've got plenty of room for the IVC to come into view. And then on the right here, this is me fanning through with the pointer upwards until I can see the IVC, and then I can stop. And at that point, you might find you need a little bit of adjustment. You might need to just rotate it a couple of degrees clockwise or anti-clockwise, or make it a little bit shallower or steeper to get a nice long stretch of IVC. But that sort of routine gets an IVC in 95% of patients. Just a little pitfall with finding the IVC. So this is the same view. We've fanned, but we've overfanned. We've angled the beam a bit too far medially, and we've gone past the IVC, and it started to show the aorta. So the aorta is marked in red. You can see it sort of goes a bit steeper, and it dives down below the right atrium, whereas the IVC drains into the right atrium. So that's why it's quite important to get a view where you can see the IVC definitely going into that right atrial cavity, because otherwise you might be mistaking the aorta for your IVC, but it just dives down below it rather than going into it. Okay, so how do we approach a sick patient? So generally in any point of care ultrasound, we're looking for sort of binary questions, big wins, big pathologies, and echo can certainly help with that. But there are certain questions we're really looking for in the sick patient. So so first we're going to stick with our 5 views or 4 views that we've been looking at there. So long axis, short axis, apicals, subcostals, and the IVC. So when we're looking at our our left ventricle, is it small, is it working hard, and is the IVC collapsible, in which case is this patient hypovolemic? So we're now thinking about sepsis, bleeding, dehydration, or is that left ventricle really hypokinetic, not pumping at all? So is this acute heart failure? Is it a really big, enlarged, baggy looking right ventricle that looks under strain, in which case it's an acute pulmonary embolism? Or is there a load of fluid around the heart and a dilated IVC that's under pressure, and is that right ventricle struggling to fill, in which case this is tamponade? And finally, is the aortic root structurally normal, or is it dilated, and is the anatomy distorted, in which case this is a type A dissection? So those are the main 5 pathologies we're trying to rule in or make less likely with echo, to help guide our differentials. So this is most applicable to the hypotensive patient, the shock patient, the breathless patient that you'll see in A&E resus. So here's our small hypodynamic heart with collapsible IVC. You can see the left ventricles, it just looks like it's working quite hard. Look at that mitral valve go. And here's our hypokinetic LV. So this left ventricle is barely contracting, it's just sort of wiggling away. And the mitral valve this time is barely coming a third of the way up. It's nowhere near that septum. And this is our severely enlarged akinetic right ventricle. I wouldn't say it's completely akinetic, but it's not bouncing as it normally would be. And it's not just matching the size of the left ventricle, it's actually superseded, and it's bigger than the left ventricle, and it's taking over the apex there. So this is an unhappy looking right ventricle. And here is our pericardial fluids, so big effusion around the heart. And what's happened to the right side of the heart here, it's looking quite flat and it's trying to fill, but every time it tries to fill, this fluid is exerting pressure and basically pushing that blood back into the IVC, so it's going to struggle to get any circulation around that side of the heart. So that is tamponade. And here we've got, this is actually a parasternal long axis view. So we've got our left atrium and mitral valve here, but what's happened up here with our aortic valve, we can see it, but there's something ahead of it here, and this is a dissection flap. And we can already see that there's something distorted with this anatomy, because the aortic root looks absolutely huge. Normally we'd expect it to be somewhere around the size of the left atrium or the right ventricle outflow tract, but this is sort of double the size of both of those. So there's something on not quite right there, and we can see that there's a flap there. Just of note, there is some other pathology on this view, so we can see this area of fluid underneath the heart, which is a pleural effusion. We'll talk about that a little bit later. Okay, so how do we put that all together in a structure that you might be able to remember? So I have a couple of suggestions for that. If you've learned in a more traditional way, say if you're doing a FICE program, or if you have gone to the echo lab and you're going through their process, they talk in terms of sort of left ventricle, right ventricle, left atrium, right atrium, and fluid, and they go through a structure there. This system of 5 E's is quite a nice point of care ultrasound geared way looking at those major pathologies, so it's a good applicable way of remembering to rule in or rule out those scary things in A&E. So I think it's quite useful for us. So the E's correspond to entrance, which is the entrance of blood to the heart, so that would be the IVC. Equal ventricles, so that would be the right ventricle compared to the left ventricle. Ejection, so that's how well the left ventricle is ejecting blood. And the exit of the heart, so that would be the aorta, and then effusions, fluid around the heart. So entrance, equal ventricles, ejection, exit, and effusions. And some people quite like that system. I think it's great for making sure you're not forgetting any of the major pathologies, but it can be, it's like the H's and T's. You can just get stumped on one when you're under pressure. So I tend to use it the more traditional way, so left, right, in, out, fluids. So I call it the Hokey Cokey, if you remember that song, put your left foot in, your right foot in. So as long as you're looking at the left ventricle and you're looking at the right ventricle, you've covered your equal ventricles and your ejection. If you're looking at the IVC, you've covered the inflow. If you're looking at the aorta, you've covered the outflow. And then no one ever seems to forget effusions, because it's that E that you always remember. You can't remember any of the other ones. Okay, so we're on to the second half of the talk where we go into a little bit more detail about some of the pathologies that you'll come across in a focused echo. We may not be able to go through all the sections in detail, but we see how we go. So we'll start with left ventricle and ejection. And I've taken out some of the measurements, the quantitative side of things for this talk, but it's something we'll probably talk about in a different session where we're doing a little bit more advanced echo. There is a role for quantitative methods of assessment, even in point of care ultrasound, but it's very much a composite tool. The mainstay of your assessment of the left ventricle, or the right ventricle indeed, is going to be visual. You're going to get used to seeing lots and lots of normals. So when you see an abnormal, it'll flag up in your brain. And then you have to get good at eyeballing whether it's very abnormal, a little abnormal, and that's where it can get a little bit complicated. So what we're really looking for is Mage abnormalities. This left ventricle is severely impaired. So just get that in your mind. If it's moderately impaired, it's mildly impaired, that's not going to make your very sick hypertensive patient on its own. So eyeballing is the most important thing. So we're looking at how that left ventricle is moving and how the walls are thickening. And as I've mentioned before, when we had a look at the parasternal long axis views, how that mitral valve is moving. So some of the quantitative methods you may want to look into include E-point septal separation. It's just quite a nice, easy point of care tool for assessing function, but fraught with a few pitfalls and error. So have a little read around it. Fractional shortening measures how much the left ventricle contracts in one single sort of plane, and Simpson's biplane is the gold standard method for assessing ejection fraction. It involves very specific software in your point of care ultrasound machine, which might not be there, and it's also quite fraught with error. So we don't tend to use that at all by the bedside or in point of care ultrasound. But any of those methods would need to be used in context with eyeballing, and really it's your visual assessment that carries the weight. So the left ventricle contracts in various different ways. It contracts so radially, a bit of longitudinal movement, and there's also this torsional movement. So it's quite a clever, twisty little ventricle, and all that adds together to eject the blood. So one particular tool looking at one area, one type of movement is not going to be enough. So visually we're having a look, and you can see those walls thickening as they're contracting. You can see that mitral valve coming up, and it's pretty much touching the septum with every contraction. So I can see that is that systolic function is good, that systolic function is preserved. Whereas on the right we've got firstly a heart that looks like it's working a little bit harder, it's a bit more tachycardic, but the walls, even though they're moving, they're not thickening, they're almost just being sort of tugged by the surrounding structures. And the mitral valve is sort of flicking up, but it's really making a bit of a half-hearted attempt. It's only coming about half the way up. So this ventricle is severely impaired. And here's another example of a severely even an inhaler a week before because he was suddenly breathless. And they gave him, sorry, my internet's a little bit unstable. They gave him a few nebulizers, but nothing was getting better. So we thought we'd just have a look, and he had this terrible left ventricle. It ended up completely changing the path of his investigations, and his troponin was over 3,000. So he'd had a good going infarct in that past week. And here again is our good, well-functioning left ventricle with our mitral valve movement. So have a look at the movement of the left ventricle in the apicals as well. So a nice way of doing this is by sticking your finger in the middle of the left ventricle, and you can see how all the walls come in towards your finger. It's sort of finger shaped. So that allows you to look for any particular areas that aren't moving like the other areas. And that brings us to this concept of regional wall motion abnormality. So people can be quite fixated on this. And I always find it's extraordinary when it's put into sort of entry-level courses, because it's very difficult. And I spent a year in an echo lab, and there was always a lot of conversation and a lot of dispute about whether there was regional wall motion abnormality. It seems like no one could agree. So it's not easy. And I've picked this as a very clear example. So these are the only real sort of examples that you'd probably be confident to talk about, to use it in your clinical judgment. But in this patient, we have a patient who has got good going cardiac sounding chest pain. So your pre-test probability is already sky high, but the ECG just doesn't match. So you're trying to build your evidence, but you just don't have enough to send someone off to have their PCI. So sticking an echo probe was quite helpful with this patient, because I could see that this free wall of the left ventricle is thickening, but this septum is staying very thin. It's being pulled by the other areas of the heart, but it's not thickening like the rest of it. And actually that's a lack of movement. It's going all the way around to the apex. The apex is just sort of jiggling. It's not thickening at all. So the regional wall motion abnormality is along the septum and the apex. The bottom of the septum is contracting a little bit, and this free wall, this lateral wall, is moving quite nicely. So definitely regional. There's one particular area that's not moving the rest of it. So we can check those findings with some of our other views. So this is quite a nice infographic to help us decide what's going on. Most patients, or most people, have a septum that is supplied by the left anterior descending artery, coronary artery. About 20% have this more dominant right coronary artery, and it's supplied by the right, but most people have the LAD supplying the septum, and everyone pretty much has the apex supplied by the LAD. So we're already thinking that's the LAD that's affected here. So what we really need to do is have a look at some of the other views. So if we look at our parasternal long axis view, which is view number 3 here, we'd expect that septum to be all hypokinetic when we go to that view. And when we go to our short axis views, we'd expect this sort of top bit of septum to be hypokinetic. So let's go and have a look at our findings. So on the left here, we've got the parasternal long axis view, and you can see that septum is not thickening at all. So that fits with our LAD territory involvement. That's the view we had before of our 4-chamber view. Oh, I don't think I've got my short axis in here, but it did correspond as well. So this patient was having an infarct, a good-going infarct, but for whatever reason, the ECG changes weren't apparent yet. So we sent these images to the cardiologist, and he was getting transferred. And as he was getting transferred, he started to reveal ST elevation. But the diagnosis was found sooner because of point of care echo. So moving on to the right ventricle. So this is all to do with pressure. So when there is big pulmonary embolism in the pulmonary trunk, or in the pulmonary vasculature, it backs up that pressure into the right ventricle and the right atrium. And that will be seen also into the IVC. So what we're looking for is that right ventricle starting to increase in size, and then not contracting properly, and then start to exert pressure on the left ventricle, which is usually the cavity that has the higher pressure of the two. So we're comparing the size of the right and the left ventricle. We can do that probably best in the apical 4-chamber views. We can use the subcostal 4-chamber views, but it's a little bit variable depending on the angle of your probe. And we look for a right ventricle that isn't contracting normally. So a lot of the systolic function of the right ventricle is longitudinal, so it's quite a bouncy ventricle. And you'll find that the walls aren't contracting like they normally would, but the apex might be contracting more vigorously. So that's considered apical sparing. So that is what they classically talk about when you talk about McConnell's sign. So hyperkinetic RV with apical sparing. I find the most useful view for looking for right heart strain is the parasternal short axis view. So looking at that sort of papillary muscle level, mitral valve level, is the LV round, and is the RV still this crescent shape? Because as that pressure increases, that crescent shape starts to become more of a blob, and it starts to press on that septum, which up until this point has been nice and round, and the LV has been a strong donut. So what is it doing to the LV? So this is what the structure should be like: a round donut LV and a crescent shaped RV. And this is what the apical four-chamber should be like. So a big left ventricle, a smaller right ventricle, and the apex of the heart in the echo is being created by the left ventricle. So the right ventricle should certainly be sort of less than 2/3 the size of the left ventricle. It shouldn't be the same size. If you want to do measurements, here are some measurements you could use. So this is from the British Society of Echocardiography guidelines. A basal diameter for the right ventricle would be about 4.2. But you have to have some quite good on-axis views of your right ventricle in your apical four-chamber to get that diameter. So this is where you'd measure it. So if you look at the right ventricle, there's a little bulge just above the tricuspid valve. Just skip that and go to the endocardium just above, and you just measure straight across, and it should be less than 4.2. On the left here, we've got our normal parasternal long axis view, and on the right, we've got one where the right ventricle is very enlarged. And one thing to note is not only is the right ventricle enlarged, but the left ventricle is working quite hard. It usually looks quite empty. It's usually hypodynamic because there's just not quite as much circulating volume going through around the left side of the circulation. And this is what I've been talking about. So this is what I feel is a much more sensitive sign. So we've turned our probe to the parasternal short axis view. This is at the papillary muscle level. So you've got these sort of kidney bean shapes just below the mitral valve. And normally we have a rounded septum, a nice bow-shaped septum, making this round donut shape. But on the right here, we've got a large RV. So already it's certainly bigger than the LV cavity, so that's already suspicious, and it's pushing on that septum every single time it's contracting. It's pushing that septum down and it's flattening it. So this poor LV is struggling, and the RV is dominating there. So something's putting some pressure on there. And here on the left, we've got an enlarged right ventricle on our apical four-chamber view. So not only is it the same size as the left ventricle, it's actually bigger. It's almost twice the size, so very abnormal here. It's not sort of contracting normally, it's sort of just wiggling around. And again, the left ventricle looks quite empty and it looks like it's working quite hard. This has all been slowed down on the right, but the right ventricle again just looks very dilated compared to the left. So one quantitative method you can use to assess the function, systolic function of the right ventricle is TAPSE. This is an M mode modality where you put the M mode line, so the scan line from the M mode, across the tricuspid annulus. So TAPSE stands for tricuspid annular plane systolic excursion. So it's how much the right ventricle is bouncing up and down with each contraction, because most of the right ventricle movement is longitudinal. So what happens is you put the line across that annulus, the ventricle bounces up and down, and it plots the movement over time. So you get this sort of these peaks and troughs in a line. And TAPSE is where we measure the slope of these little mountains. So you get the distance time marker from your ultrasound machine, which will just be caliper in M mode, and you put one end of the caliper at the bottom of the mountain and you put the other end at the top of the mountain. And as you can see, the M mode has drawn the TAPSE as a sort of brush stroke, so it's made up of lots of sort of brush stroke lines. So you just pick one of those brush stroke lines and follow it up. So one end of the caliper at the bottom and one end of the caliper at the top, so they don't cross across different brush strokes. And what that does is it measures the height of these bumps, and anything over 1.6 is considered normal function for the right ventricle. So in acute right ventricular increased pressure, that should be impaired. Okay, so this particular machine has it marks it as two sort of long markers, but you would just place the caliper at the bottom and at the top of this line. And as you can see, this one measures at 2.7 centimeters, which is well above 1.6, so normal. So moving on to entrance, so this is our IVC. So the IVC is collapsible on this view. We looked at that before, and we did talk about measuring it 3 centimeters from where it enters the right atrium. People talk about M mode a lot with the IVC, so you can put M mode across where the IVC is collapsing there and get the patient to take a breath in and a breath out, and you should be able to see that more than 50% collapsibility. People talk about the sniff test, so if it's not clear if it's collapsing or not, they can do a short, sharp sniff. And the idea is that it keeps it in your 2D view a little bit better, so that collapsibility is in a shorter space of time, so you're more likely to see it on M mode. It's not validated, however, so traditionalists will say, well, that's quite pointless, it doesn't really tell you anything, but I think it does give you some idea about whether it's collapsing or not. Okay, so traditionally 1.5 to 2.5 centimeters is supposed to be normal. My IVC is about 2.8 to 3 centimeters, so it does vary hugely. And it should collapse more than 50%. So some people work that out as a caval index. So the expiratory diameter minus the inspiratory diameter over the expiratory diameter times 100, and over 50% suggests they're fluid tolerant. So I would recommend measuring in 2D. That's just because you don't know where your M mode is exactly placed when the patient is breathing in and out. But I think the M mode is quite useful for looking at collapsibility. You always get slightly better resolution with M mode. So this is quite a nice image. This image is inverted to what you'd normally get if you were having a look at a subcostal view or an IVC on your echo. So we've got our liver on the right and your heart on the left. But that IVC is not collapsing with respiration, which is unusual. And we can see why. There's a bit of pathology on here. We've got some fluid around the heart here, which is where it shouldn't be. And this is the right side of the heart trying to expand. So this fluid is exerting pressure on the right side of the heart, and that pressure is backing up into the IVC. So this is looking like it's heading towards tamponade. Okay, so we've done entrance, we've done equal ventricles, we've done ejections. We're moving on to exits. This is the aortic root. I'm going to skip through this relatively quickly because it's a little bit rarer. I think it's probably more important to talk about your pericardial effusions. So this is the normal structure for an aortic root. It's you have your left ventricle outflow tract and then your aortic valve, and then there's a little sort of divot, a little outpouching either side, just above the aortic valve where the coronary arteries come off. And this is called the Sinus of Valsalva. And this is traditionally where we'd measure the aortic root. It's supposed to be its widest part. And usually that is the structure. So if a patient is nice and healthy, this will be the structure. It'll go out a little bit, come in a little bit, and then just go straight up into the ascending aorta. And so we can measure across there. Now, when people have chronic hypertension, it might become a little bit dilated. You may lose some of that structure, but certainly with dissection, that structure can become completely disrupted. And you might even see a dissection flap, which was noted in one of the examples. And if you're at the stage where we're starting to use color Doppler, as you can imagine, having this dilated will pull the aortic valve cusps apart, and you'll end up with some aortic regurgitation. So if you put color over this area here, you will see a jet of aortic regurgitation into the left ventricle as well. Now, is every dilated aortic root a dissection or an aneurysm? No, of course it's not, but there is a good correlation between them. And if your pretest probability is high enough, if you think this patient, has got good going chest pain, I don't really want to give them ACS meds without knowing it's definitely not a dissection because it is going through to the back a bit, and you see a big dilated aortic root, your suspicion will become quite a bit higher with echo, and should go ahead and do your CT before thinking about anticoagulating them. So this is our just a graphic of the aortic annulus. It's a sort of virtual ring formed by joining of all these valve attachments, and we measure from this orange line here, the sinus of Valsalva. So they say measure with the aortic valve closed and leading edge to leading edge. That means the edges that the ultrasound beam hit first, that's where you lay your caliper. So it's this top edge here, and then this inner edge below gives you your dimension. But to be honest, valve open, valve closed, leading edge, or inner to inner, outer to outer, it's all going to give very, very similar measurements. This is just to make you aware of different sizes of the aorta as you go round. It does vary a fair bit. So measuring the sinus of Valsalva is going to be the largest point of the aorta for most people, and we sort of tolerate up to 45 millimeters. But we, in emergency medicine, we talk about sort of upper limit of 4 centimeters in a patient that we've got quite a high suspicion for. So anything over 4 centimeters is considered aneurysmal. Okay, so this is just measuring leading edge to leading edge. And this is the study where the 4 centimeters came from. So at 4 centimeters, the risk of it being a dissection becomes much more significant. So here we're going to have a look at some aortic regurg. So if we look at this 2D image of the parasternal long axis view for this patient, we can already see we don't have that nice sinus of Valsalva there. So the structure has already been a bit distorted. It looks dilated. We'd expect a ratio of 1 to 1 to 1 between the right ventricle outflow tract, the aortic outflow, and the left atrium. And I can see that this aorta in the middle is bigger than the left atrium and the RVOT. So it already looks unusual. And we're going to stick some color across it. And this green flash is the aortic regurg jet. So it's at some quite high velocity. And as the aortic valve closes and the left ventricle relaxes, it's sort of sucking a jet of blood back into the left ventricle, which is visible on color Doppler. And here's just another example of a dissection flap. So this person has a sort of inverted parasternal long axis view. Actually, I think this is probably a subcostal view here. And they've got the aortic valve in the middle, and there's a dissection flap visible just above that. So the same pathology here. We've got the dissection flap just beyond the aortic valve and the parasternal long axis view, but it's also visible in the parasternal short axis view. So it's almost like there's another cusp coming in. So this is a little debate we had on Twitter. Can dissection be excluded with POCUS? For me, this is all about pre-test probability. So if you've got someone who you think is very low suspicion of having a dissection, you think there's a good other reason for them having chest pain, you think, oh, there's some ECG changes, this is an ischemic type chest pain, and you've managed to do a point of care ultrasound where you've imaged the aortic root, perhaps even a bit of the ascending aorta, perhaps even a bit of the aortic arch. You're seeing quite a lot of it. There are always going to be areas that you can't visualize with echo, and so it's just about what your suspicion is. But point of care ultrasound, as you know, is a composite of your examination and your clinical suspicion, and it will just either add or take away from your suspicion. So if I've got my patient who I think is having an ischemic heart attack, but he did say, but he's got, you know, a little bit of difference in blood pressure, or his mediastinum maybe looks a little bit funny on the x-ray, this can be quite reassuring if you've got a low suspicion and you've got a normal aortic root. And obviously the more imaging you can do, the better. So can it be ruled out? I think clinically with point of care ultrasound, it can be ruled out to a low enough suspicion for you to move forward. So the final E, effusions. So we're going to use the descending aorta in the parasternal long axis view as our landmark for this, to establish whether it's pericardial or pleural, because this can really trip you up. And then we're going to look for whether this is causing any pressure on the heart that might be leading to tamponade. So the signs of tamponade are to do with whether the right ventricle and the right atrium are able to fill in diastole. So you'll need to be able to identify the diastolic phase of that cardiac cycle to make sure you know whether it's collapsing at that particular point in the cycle. So descending aorta is our landmark. So here, this is a parasternal long axis view, and the descending aorta is this little circle below the left atrium. A pericardial effusion will come up above the descending aorta, and a pleural effusion will drop down below the descending aorta, and it won't come up to this little peak. So that's how you tell the difference. Sometimes people have both. So here we've got an example of pericardial effusion on the left. So it comes up to a sort of point just above the descending aorta in this atrioventricular groove. And a pleural effusion can look like a significant amount of fluid. It can look like it's in the pericardium because the structures around it are very bright, but it's not coming up into that little groove. It's coming about halfway up the aorta and then dropping down. So this is pleural. Here we've got both. So we've got one effusion that's coming up to a point above the descending aorta. So this is the pericardial fluid. And here's also a pleural effusion, but the pericardial fluid is just pushing it a little bit further away from the aorta than it was in the previous views. So we can measure an effusion at any point really, but generally when it's at its biggest, and in diastole ideally. In the echo lab, we considered anything above 2 centimeters significant. Patients can have physiological effusions up to 2 centimeters without any problems at all. And you'll find there are lots of patients who have this little sliver of pericardial fluid around their heart. That is not an effusion. Don't comment on it as an effusion, just call it physiological pericardial fluid, and that is fine. If you've got a pericardial effusion that is collected very quickly, so for example, in the context of trauma, a small amount or a small depth of fluid is obviously much more significant because that pericardium doesn't have a chance to stretch. And tamponade is very much a clinical diagnosis. So we had a patient who was looking quite well, but had a bit of chest pain. Someone did an echo for practice and found a pericardial effusion. It was about 3 centimeters, so pretty good going. And there was this bounce of the right ventricle. And so he immediately got on the phone to cardiothoracics, convinced that this was a tamponade. The patient was sitting upright in bed, you know, had a heart rate of about 75 and just complaining of some pleuritic chest pain. So clinically, not a tamponade at all, couldn't possibly be a tamponade. And that's really the clincher. And what happened is he'd mistaken this bounce of the right ventricle wall as diastolic collapse when it was actually just some bounce and systole. So as the right ventricle collapses, if there's a bit of fluid on the outside, it will have a bit more of this dynamic motion of the free wall. So clinically, we're looking for all the things we normally would be, so tachycardia, hypertension, distended neck veins, and pulsus paradoxus. And on the right here, we've got just some diastolic collapse here. So it can be quite difficult to establish exactly what phase the cardiac cycle is in. So I always recommend putting telemetry on, and you can go through your ECG trace to end diastole. The middle of the QRS to know that you're definitely having diastolic collapse. You just wind it through the clip until you're at that point. And this is something called the swinging heart sign. So if there's a big sack of fluid and the heart is sort of hypodynamic in it with the right ventricle working hard to fill, you get this sort of swinging heart sign as the right ventricle is being pushed when it's trying to fill in diastole. So it's another sign of tamponade, but it's all down to clinical judgment. And obviously all this pressure on the right side will back up into the IVC. So if you've got a patient who doesn't have a collapsible IVC, that's much more in keeping. But if you have a patient who's got a collapsible IVC, this can't be tamponade. You need to have a think again. Okay, and that's it. So I've taken out some of the measurements, the quantitative sections. There's lots more we could talk about in the future, but it gives you a quick overview of what a focused echo should entail, and also just a way to structure your report. So once you've done your echo, so all my reports start with a pre-test probability and an indication, so have an idea of what you're looking for, and then your report should focus on those 5 E's and cover left, right, in, out, and effusions. And if you do that, then I think you've got a really good sort of governance process and good structure for your point of care echo scans.
Thanks very much, Anna. That was fantastic. So there haven't been any questions in the chat, but would anyone like to just unmute themselves and ask any questions from the talk?
I guess I've got a question because I often find assessing the IVC a bit tricky for collapsing and inspiration. I'm always not quite sure, am I really seeing some collapse there, or is my sort of slice of the IVC slipping on and off of it a little bit? And am I kind of getting a false sort of positive on the collapse? So I don't know if you've got any tips for really reassuring yourself that you've got a good, stable, longitudinal slice of that IVC on inspiration.
So it can be really difficult, can't it, when you've got a patient who's breathing in and out and the whole abdomen moves as they're doing it. In the echo lab, we did all our sort of collapsibility assessments on M mode. So we did use the Sniff Test, not validated or whatever, but we did use that quite a bit. And I think you just use it together. So the M mode will give you a better resolution. It's just going across one scan line. And so as long as you can get that nice black line where the IVC is in the middle of your view and get the patient to take a breath in, it will give you a much better, more consistent view of whether it's collapsing or not. So I'd say get used to using that. On 2D, I think that there might be some scope for you to just sort of refine your skills a little bit. So what might be happening is that you're not getting a good stretch of IVC, that you're only getting sort of more small little sections of it. And if that happens, there's obviously a lot more scope for it to come out of your view when the patient takes a breath in. So try my little dance, and if you are finding with my sort of my turn, flip and fan dance, you're not getting good stretch, just rotate your probe a few degrees anti-clockwise, and that can just elongate it out a little bit and you'll get a longer stretch. So I think it's probably a bit of practice to get yourself a good length of IVC, but it will come, it will click one day.
Okay.
Yeah.
Thanks.
Yeah, I would just add, sometimes I actually quite like to get a transverse view as well, because as you were saying, like on long, sometimes you can easily just slip off and you might just be scanning the edge of the IVC and you might not really know. So if you're not sure, just have a look at transverse as well and you'll get an idea of collapsibility there too. But yeah, if the patient's like really breathless and they're breathing hard, then obviously the IVC is going to collapse because there's just they're generating a greater sort of negative intrathoracic pressure from their respiratory distress, for whatever the cause of that is. And so then that's not necessarily a good estimate of volume state. So it's just one piece of the puzzle that you factor in with everything else. Yeah. Any other questions from the talk?
Anna, sorry, can I just ask a quick question? In terms of the volume of pericardial effusion, how do you estimate it? Is there, I know there won't be any accurate, but do you do that 1 centimeter between 1 to 2 and more than 2?
Yeah, I basically look at more than 2. So I try and interrogate the heart as much as possible in sort of 3 dimensions to see where the effusion is. For some reason, all the effusions I find tend to be around the RV. I'm not quite sure why. And then I pick the ones that have the region where it's the biggest depth, and I do the measurements at that point. Now that's going to be more significant if that is around the right ventricle, because it's a low pressure area. So you can comment on the depth of it, whether there's any bounce, whether there's any systolic or diastolic collapse. But I know in the echo lab that if it was less than 2 centimeters, we called it physiological pericardial fluid. We didn't even bother calling it an effusion at that stage. But in the context of trauma, because obviously they don't see those sorts of patients, you can have tamponade with a 1 centimeter collection of fluid. So that would just be my caveat.
Do you do it in a parasternal long axis view and just at the top between the surface and just the thickness of fluid just around the right ventricle? Is that where
Yeah,
you
in all
measure it?
honesty, I probably measure it more on the short axis view. So I see, I establish whether it's pleural or pericardial on the long axis. And then when I look at the short axis, it just allows you to go from top to bottom. And then I pick my points where I'm going to measure it on there.
Okay. Okay. Thank you.
Yeah, and if you want to know more about tamponade, because we actually discussed that topic in quite a lot of detail last month at the same forum, and that recording is up on YouTube, and there's a link via the Slack group. Actually, maybe I'll just quickly share my screen and just quickly show you the Slack group so you can see how it works. If you haven't already joined, then the link is in the chat, so please join. And if there's any problems joining with that link, I'll put my email as well, so just send me an email and I can send you a personal link. But yeah, this is the Slack group, London EM POCUS, and these are the different channels. So general is sort of the main channel where everyone's a member. We'll put the announcements for the monthly teaching there. Introductions is where you can just say a bit about yourself, which is good for networking, finding people who are interested in the same things. Maybe you have a little project, you can connect up with someone. The monthly online teaching, that's what tonight is. And we've already had a few of them. And so we've got the links here as well. So you just click on the link and we've got, so yeah, last month we did shock. So I talked a bit about shock, and Matt Blundell did a really fantastic discussion of tamponade, going into quite a bit of detail about like timing the collapse of the right-sided chambers to make sure it's diastolic collapse by looking at the valves. Really good. So yeah, I would recommend having a look at that too. And you can actually change the playback speed. You can, because I talk really slowly, so you can like speed my bit up to like 2 times. And then when you get up to Matt, you can go back to 1.5, whatever is suits you. So yeah, check that out. And the Slack group, we're hoping it becomes a bit of a community. So yeah, please join up and spread the word. You can get the invite link here by just pressing copy invite link, and you can just WhatsApp it or email it to any of your colleagues. So far, we've got 75 people there, but we're hoping, you know, it grows and grows, and it becomes a forum for sharing knowledge and inspiration, as well as these monthly sessions. Cool. Any other questions on Anna's talk or on any other echo topic? Timo asks, are there any other cutoffs if the patient is symptomatic and has an effusion? Are you there? Do you want to unmute yourself and just elaborate on that a bit, Timo?
Hey, hi everybody. Just my question. So we recently had a patient that was in pain, so had like pleuritic chest pain and had an infusion that was like 1.5 centimeters. And I thought that might have been the reason why that patient was in pain. So are there any other cutoffs? Because you earlier said that the cutoff for you for a just physiological one would be just 2 centimeters or about 2 centimeters.
So that doesn't mean that smaller collections aren't pathological. Most people only have a sliver of pericardial fluid. I mean, it sounds very much like your patient had pericarditis and so had a little bit of inflammatory effusion there. So I would have that would have sort of supported that clinical diagnosis, because that often goes together. But in terms of intervention, in terms of needing to drain that effusion at 1.5 centimeters, there's really no chance, particularly if it's a medical cause, of it causing any problems. So that would just, if there's some sort of underlying pathology behind it, be it autoimmune or inflammatory or infective, they probably would just have sort of serial echoes to make sure it's not getting bigger.
Great. Actually, there was one case from the chat earlier that Matt, your colleague at Lewisham, brought up. Did you want to tell us a bit about that case, Matt? It was a post-ROSC patient, and you.
Yes, yeah, it was a 55-year-old, I think, female. She came in from a cardiac arrest in her front garden. So when she arrived, she was really hemodynamically unstable. She had blood pressures sort of around 55 systolic-ish, and was really inotropic dependent. So we had a look at her heart with the ultrasound, and I thought she had terrible LV function. So not being an expert, I got someone else to have a look at it, and they said, no, the LV function's okay. It's more of a hypodynamic right ventricle. But I got a bit lost at that point. So I was wondering if there's a way you can differentiate easily between whether it is LV impairment or if it's hypodynamic right side problem.
I guess, yeah, it's difficult to know. It would be weird to have a sort of hypodynamic right ventricle on its own. You'd expect the left side to be working hard if you've got a shocked patient. What did you think the cause of the shock was?
We was working with cardiac at that point. She later had a CT. It turned out she had an atraumatic subarachnoid, is what we were thinking is the cause of the arrest. But I think it's probably more just maybe a bit of myocardial trouble post from the ROSC.
Yeah, I mean, subarachnoids can do funny things to your heart as well, can't they? We very much invite you guys to bring your anonymized scans and share them in these sessions, because it would be great to have a look and have a sort of group chat about these ones. We're hoping sort of we'll develop a bit of a kind of MDT community where we go through our scans in the future. Sorry, Matt, without seeing it, I'm not sure I can comment.
Yeah, I guess in general, in terms of assessing LV and RV function, Anna's talked a bit about that. I like to just imagine a point in the middle of the chamber and then just look to see the walls moving in towards that point. I guess you can do that for both the LV and the RV. And then there's some of the simple measurements like MAPC, TAPC we talked about, EPSS. I think, would you agree, Anna, you can get most of your information just from that without using any sort of more complicated things like biplanar ejection fraction or any Doppler?
Yeah, absolutely. I think you'll get yourself into a confusion, sticky situation if you use too many measurements in POCUS, because they all just look at certain points of the left ventricle unless you're using a full Simpson's biplane. So I don't actually use any measurements in point of care ultrasound anymore, except for TAPC. So I will use TAPC for right ventricle, because right ventricle it's quite predictable in its movement. It is mostly longitudinal. It's a bouncy ventricle. So if it looks impaired and you've got a low TAPC, that is unusual. So that's the one measurement that I think is quite helpful.
Yeah, great. Any other questions from the floor? Or yeah, if anyone has an image handy and you want to bring it up and share the screen, we're happy to review images as well.
I might just see if I've got one good case. There was one that I thought might be worth showing.
Sorry, I have a question. Sorry, it's a little bit of query. So in people who have cardiac arrhythmias and their heart rates are quite fast, for example, in atrial fibrillation, is there any reliable way to assess their cardiac function? Because at that time, everything seems to move very fast. It's quite difficult to assess whether their ventricle are contracting very well.
Yeah, you're absolutely right. So again, in the echo lab, if we get someone in fast AF, you will find a blanket statement of left ventricular systolic function cannot be assessed due to fast AF. Please rate control. So the answer is no. The professionals will say no. But having said that, sometimes the ejection fraction or the left ventricle appears to be contracting well, even though the patient's in AF. So in that context, you can say, despite the patient being in AF, a left ventricular function appears preserved. So you can say, right, well, it's working pretty well, even though it's going to be struggling to fill properly because of the AF. So you can say it's preserved, but you can't really say it's impaired until you slowed it down.
Yeah, obviously doing measurements in that context is going to be fraught with error, isn't it? Because each contraction is going to be different. So like if you try and measure something like MAPC, it's going to be meaningless.
Yeah, so you can't do diastology, you can't do anything really. Just going to show this this one here. Does anyone know what this is? So this is an apical 4-chamber view, and it's we're looking at the right side of the heart a little bit more. So So we've done a slightly funny view so that the heart's, the right side of the heart's in view. Anyone got any ideas? Oh, too many answers all at
Free
once.
Easter egg. Free Easter egg.
Thrombus in the RV, maybe.
Thrombus in the RV we had. Was that you, Matt?
Yeah, maybe. I'm not sure. Man.
Yeah.
Or a myxoma.
Or clot.
Timo's thrown a myxoma into the mix. Karush says clot. So we've got a couple of clots. Trang's gone for a clot. We seem to have lost our host again, Anna. Hopefully she'll rejoin in a sec. So yeah, I thought it was a clot too, but we'll find out from Anna shortly. Yeah, there is Blop sign on exam, Karush says. Can you enlighten us? What is the Blop sign, Karush?
When you have cardiac myxoma.
And it's called the Blop sign, is it?
Yeah, because it's got plop.
Okay.
It sounds like that.
All right. Is that a real sign? You just make that up.
I swear to God, it's a sign.
Okay, cool.
I think.
You just dropped out, I think, Anna. It's okay.
Oh.
So we had a couple of clots and a myxoma. Just the answers for that video that you showed.
Yeah, so it's a thrombus in transit, that was. So it was a thrombus working its way from a DVT into the
I think maybe Anna's got an unstable connection. But yeah, I hope you heard, she was saying it's a clot in transit. So a busy clot. People to see, places to go. And Trang says you need to sit with Steph on patient chest. Is this to elicit the Blop sign you're talking about, Trang?
I'm just guessing. That's what Karush means.
Okay.
You're dead.
Okay. Are you with us, Anna? Okay. Any other questions from the talk or on echo generally? I can do my best to field them. Okay, so just before you go, I just wanted to post a couple of other links for you. As we've been going along, you may have noticed in the chat, I posted a link to a free online echo simulator from Toronto, which is really nice, and also a free download to a really detailed echo textbook, which is good to use as like a reference. If you want to look up a specific topic, it's about 500 pages, so I wouldn't recommend trying to read the whole thing from front to back, but it's great just to have as a reference, like if you want to know a bit more about a specific thing like mitral regurgitation, for example, there's a few pages on that. And then I'm just going to post now in the chat a couple of other sites that I find really useful. So one of them is, it's called Core Ultrasound now, and within Core Ultrasound, there's a couple of different websites. There's 5 Minute Sono, and there's, what's that one called? Ultrasound Podcast. So 5 Minute Sono is great because it's like just little how-to videos just to remind yourself of how to do whatever scan it is. On pretty much every POCUS topic is on there. And then Anna also wanted to share this, another Canadian site, resuscitative sonography. So this is, as well as echo, also talks about lung. I had a quick look at that today. It looks really nice. So yeah, you're back with us, Anna? Come in, Anna, are you with us? No. Everyone else is with it. I'm not just talking into a void. Is everyone else there? Can someone say?
Yay.
Okay, good. Just Anna. So it's a bit disconcerting when you're just sort of talking into a void of silence. Yeah, I think Anna's having some trouble, but I think we've pretty much wrapped up. Unless anyone had any final questions. Hey, Anna, are you with us? You're just dropping in and out a bit.
Yeah, my internet's tired.
Okay, cool. I think we're pretty much wrapped up. Nobody else has asked any further questions. And you were saying clot in transit for your video. Well, I'll edit all of this out of the cut, don't worry. Okay, great. Well, thanks very much, everyone, for joining. Feel free to turn your videos on to say goodbye, so I can see your faces. It would be lovely. You don't have to. And yeah, check out the Slack group. Yeah, please join the Slack group, and you can see when the next session is going to be through the Slack group. Please invite all your friends. Yeah, thanks very much for coming. I hope it was useful. Great to see all your faces. Thanks very much to our beautiful and talented presenter, Anna, for an excellent talk.
Sorry about my internet.
That's okay, it wasn't too bad.
Bye, everyone.
Thanks, everyone. See you
Thanks,
around.
Bob.
Thank you. Bye.